Door closes. Good morning, students, and Happy New Year, all of you. And this New Year's comes to you in the form of examination, which are bound to appear maybe in the month of March, April, whatever it is. And I hope that you are all well prepared and ready to face the examination system. So, for today's lecture, we will have a very short, brief way of discussing the sinus, fistula, and the lymphatic system. The primary reason being you do get one of these systems in your short case, sometimes in a long case. The difference between what we have studied so far regarding the lump or ulcer is different from the study of a sinus or fistula. Even for lymphatic system. In lymphatic system, the individual lymph node can be examined as a lump, but the lymphatic system is never called a lump. The reason is whenever a swelling occurs in a lymphatic drainage area, it should be called lymph node. So it is an area specific. Do not call it a swelling. You call it as a lymph node. And remember, normal lymph nodes are not palpable. It should be fixed in your mind. Whenever they are palpable, they have to have some pathology. It may be very short duration, it may be chronic duration, it can be malignancy, tuberculous, whatever reasons. And that is our problem or our importance is to study what is the cause. So considering to start with from a sinus and fistula. Okay. These are all common cases for short examination cases. And remember, this is very important because a sinus or a fistula is a spot diagnosis. Because if you see in your MCQ questions, there is a photograph which shows a sinus or a fistula at a particular point. And simply on the location, we can identify what type of fistula it is or a sinus it is and what is the etiology, pathology, clinical features, management, everything. So it is a spot diagnosis. We do not describe sinus or fistula in the form of a lump or ulcer. So it is only you have to differentiate sinus and fistula. Your concept regarding sinus and fistula should be very, very clear. What is sinus? Leading from a surface down to the tissues. Getting it? Or it is a cavity in the tissues which has got connected to the surface and forming a sinus. Thing is same. In first way, it is going from outside to in. In second type, it is coming from inside to out. Both of them are sinuses. One is a blind tract, another is an open tract. And over the long run, the sinus, though initially lined by granulation tissue, is ultimately epithelialized. So getting it? Sinus is a blind tract. As against fistula. Fistula is a communication between two epithelial surfaces. Okay. And what they are commonly? They are commonly between a hollow viscous and a skin. Okay. This hollow viscous to the skin is called as external fistula, and whenever they are connecting two hollow viscera to each other, they are called as internal fistula. First is sinus, which is a pure blind tract, fistula, external fistula, internal fistula. In both cases, over the long run, they are all epithelialized. That means the granulation is replaced by epithelium. Now what is happening? Due to epithelialization, there is no question of healing because for nature they are already healed. Epithelialization is the ultimate of healing. So sinus is happy, fistula is happy that I have healed. What is problem for us? Their healing is of no use to us. We want them to collapse. We want them to be removed. We want to stop that discharge. Understand? Now, how do you proceed for a fistula or sinus? The history is very important because many of the sinuses are present with congenital, that means at the time of birth. The example is very common: preauricular sinus, branchial sinus, branchial fistula. Though they are not at birth, they will be at the middle of the age. Whenever sinus is due to osteomyelitis, there will be history of fever, bone swelling and pain. See, the history is diagnosing the type of fistula, type of sinus. There can be history of discharge of bone chips. Patient says some white structure comes out of my sinus and it heals. Again after a few months, something will come out, again it will open. So this chronicity is a nature of a fistula or sinus. The examples are, if it is congenital, pre or post auricular sinus. Most of the sinuses which we deal are acquired. That means over a period. Commonest among them, which you get in children, it is a medial mental sinus. That means occurs in the midline or just by the side. And the cause is tooth abscess. The very common form of sinus which we come across is a pilonidal sinus. Situation. Because we are all diagnosing these sinuses depending on their situation. Pilonidal occurs in a midline in the anal region. So you have diagnosed so many things only on the specific site. These are the few examples. First is a pilonidal sinus. If you can see, it is above the anus in the anal cleft. Just above the anus in the anal cleft. This can be, ideally they are all midline, but due to infection they can also have opening laterally. These sinuses can have multiple openings. It is a pilonidal sinus. Here, just behind the ear, you can see a preauricular sinus. This is congenital sinus, but it persists for years together because whenever there is infection, there is accumulation, the pus will come out and patient will be happy for 6 months to 1 year. Again it recurs. So this type of epidemic or periodicity is the nature of a sinus. Mandibular sinus. Whenever there is infection of this maxillary or last tooth, mandibular sinus forms. But mandibular sinus is most common in tooth decays. The last picture is showing is a tuberculous sinus. Most common form or causative agent of a sinus. Here you can see the common site for tuberculous sinus is axilla and chest wall. So sinuses occurring on the chest wall, always think of tuberculosis. So the site itself is highly specific. Past history, ask the patient history regarding tuberculosis, ulcerative colitis, Crohn's disease, because multiple fistulas are a diagnostic of a Crohn's disease. Ask the history of associated pain. Whenever pain occurs, the nature is inflammatory or there is a blockage of the whole tract. That blockage, accumulation of inflammatory material also gives rise to pain. Fever and redness also suggest inflammatory. The history patient is giving. All colorectal carcinomas, if the patient gives history of carcinoma of the rectum, they ultimately land in anal fistula. Family history, there is usually a history of a similar sinus in the past in family. Commonest is Crohn's ulcerative colitis. They run in families. And it is said that fistula in ano is also seen many times in other member of a same family. So fistula is ano also has got a familial record. Local examination. Here you have to be very particular. This we are talking about a single sinus or multiple sinuses. First, you must know how many sinuses are there. Number. Most likely fistulas are single. In some cases, mainly like Crohn's disease, urethral obstruction, you get what is called as a watering can perineum. That means in the perineum around urethra there are multiple openings. And what happens? The urine comes out of those openings. So it is called as a watering can perineum. The disease of actinomycosis, which is fungal in origin, does give rise to multiple sinuses. Sometimes ulcerative colitis also gives rise to multiple. Single fistula are commonest, multiple fistula in a major pathology. The position. We have just discussed the position of a sinus itself is a diagnostic feature. What is the opening look like? This is equally important. Whenever you at a opening of the sinus, you can simply judge the depth of the tissue. And whenever we call it as a sprouting granulation, when you see that the excessive granulation coming out of the opening, that means nature is trying to remove something from that sinus. And what is likely? It is likely to be a sequestration in case of bone. It can be any foreign body, and for us, it can be infected or non-absorbable suture. They are the commonest cause now for chronic sprouting granulation in a post-operative wound. Simply look at the sinus, you will say that something is definitely there. You remove it, the sinus will heal. As against that, in tuberculosis, we all know the edges. Edges of a tuberculous sinus are undermined. Never forget this. Light, thin, bluish, undermined membrane. That means if you put some probe, you will see that they are empty. That is undermining of edges, diagnostic of tuberculous sinus. Branchial fistula, the opening in the lower third in sternomastoid muscle. Just in front of sternomastoid, the diagnosis is branchial fistula. Pylorus sinus behind the anus. And a single sinus over lower jaw, it is the osteomyelitis of a caries tooth. Understand? So these are by position itself you can diagnose. Multiple indoor sinuses in upper part of neck, they are of a fungal origin, that is actinomycosis. It is common in some areas of our country. What is a discharge? Apart from where they are, what type of discharge is there from the sinus? If you carefully look at that, you will know the diagnosis. In osteomyelitis, foreign body, there will be pus discharge. In fistula, or a sinus related to any colon or anything, there will be pus or serosanguinous. Serosanguinous is diagnostic of a tuberculous ulcer. Just watery reddish colored discharge keeps on coming over months, years. Sulphur granules, they were present in the past in all actinomycotic sinuses. That is a Madura foot. Remember, Madura foot is also asked as a short note. And whenever the fistulae, particularly fistulae, whenever related to GI tract or urogenital tract, you find either urine, fecal material or bile coming out of a fistular tract. They are enterocutaneous fistula. You must examine surrounding skin. In surrounding skin, if there is previous healing, because it is a chronicity, the sinus or fistula heals, again reopens. And that is very common in a foreign body in case of osteomyelitis and tuberculosis. Okay, so discharge and surrounding skin. Then now we are going to the actually palpation. What is a palpation? First, you have to palpate for following points. First is tenderness. If it is tender, think of infection. Palpate the wall. You have to palpate the wall in 2 fingers. And if it is thick, you also again think of a chronic fibrosis which is due to secondary infection. You have to palpate the mobility. Whether the sinus is mobile over the deeper structure, it is likely to be free from that structure. And whenever they are fixed to the bone, you must think of osteomyelitis. If there is lump in the neighborhood, now what is happening? A lump is in relation to a sinus is most likely to be tuberculous lymphadenitis. So in palpation, tenderness, wall, mobility and lump. This is common for a palpation. The specific examination for a sinus or fistula is a probe examination. Remember, it is very important to be very cautious with the probe. The reason is you may convert a sinus into fistula. irregular or slightly forced can open that sinus into an internal viscera. And what it will lead to? It will be fistula. So this is what is called as a acquired artificial or iatrogenic fistula. You must avoid that. Okay, and how do you examine it? In the probe, what you are supposed to do? First, you have to diagnose the depth of sinus and the direction, because direction is very important, which structure is likely to be attached. You must try to find out if there is any sequestrum by touch. There will be some type of noise, whether there is a communication with the hollow viscous or not. And remember, when you remove the probe, whether the fresh discharge is coming out or not. This is fresh discharge coming out is a sign of a chronic non-ileal sinus. Most important, as in a regional examination of a lump, you have to examine the regional lymph nodes also in cases of a sinus or fistula. So this is how you are examining the fistula. Local examination is over. General examination. In general, whatever the site of sinus, you have to examine the particular system. How? Whenever the fistula is related to anus, you have to go for examination of anal canal in terms of PR examination, proctoscopy, if required, sigmoidoscopy. Also examine the whole abdomen by palpation. Multiple fistula in perineum and scrotum, always look for lower urinary tract. And if the sinus is or hip joint, you must examine the hip as well as spine. So we want to find out where the origin of that is, general examination. How do you classify sinuses? Classification very simple for sinus and fistula. First is congenital. Preauricular sinus we have discussed. Traumatic, following a trauma, a foreign body may be implanted in the deep layer and the body is trying to throw it out. Inflammatory, osteomyelitis, tuberculous, actinomycosis. Neoplastic, it is a degenerative malignant growth, can give rise to sinus or fistula. And pilonidal sinus, these are the classification of sinuses. Congenital, traumatic, inflammatory, neoplastic, miscellaneous or idiopathic. Okay. So if you remember this type of classification, you don't have to bother much, don't think much. Congenital, traumatic, inflammatory, neoplastic, idiopathic. You are through. Okay. Same thing applies to fistula. Congenital, traumatic, inflammatory. Here congenital, branchial or thyroglossal fistula. Traumatic, salivary, pancreatic, biliary fistula, fecal fistula or urinary fistula. This is traumatic. Many times it is post-operative or blunt abdominal trauma. Inflammatory, for us, commonest is appendicular fistula. That means, or a diverticulosis. Diverticulosis is one of the commonest cause for causing a colonic fistula. These are the different causes. Malignancy stands above all. Most of the malignancies do give rise to a non-healing sinus or fistula over the long run. Every malignancy will give rise. Carcinoma of the rectum either coming out or it will involve the adjacent structure. You understand? Grade 4 malignancy means what? Whenever a neighboring viscous or structure is involved, it goes to T4. So all T4 malignancies present in form of sinus or fistula. It can be internal, it can be external. In females, CA cervix involves urinary bladder. Extensive malignancies in abdominal wall do present as a fecal fistula. Okay, so it is a grade 4 malignancy, that is T4, gives rise to fistula. So why the sinus or fistula is not healing? That is a major problem for the management part. Patient keeps on coming for years together, but the sinus or fistula is not healing. Maybe 5 months, 6 months, again it will come out. So what are the common causes? You must remember this. Presence of foreign body, persistent infection, distal obstruction. Remember, if it is a distal obstruction, it will find some way. It will find some way of coming out, either a pus or some internal material. If there is no rest to the part, Again, fistulas are not going to heal. Equally important, epithelialization. That means epithelialization of the whole tract, which will make it non-healing. So what is the treatment? You have to remove the epithelialization by curating. Malignancy. Unless you treat the malignancy, fistula is not going to heal. In general surgery, non-dependent drainage. Remember, we always talk of a dependent drainage. In non-dependent drainage, the tract becomes curved and it takes a longer time. That is why it will also epithelialize, and this is going to be inadequate drainage and continuous fistula. Associated fibrosis. Fibrosis doesn't allow the sinus or fistula to heal. Similarly, if patient is undergoing radiation therapy, his fistula or sinus is less likely to heal. And specific causes, tuberculosis, actinomycosis. So if you remember these 10 things, you are definitely able to write the sinuses causes of a persistence or non-healing of a fistula. Investigations. Very simple investigation. First is CBC, complete blood count, ESR. ESR is particularly raised in case of tuberculosis. Increased TLC, DLC or WBC suggests infection. Must know what is a fasting and postprandial blood sugar. In case of a local examination, involvement of any bony structure, X-ray is a must. And also, many of the foreign bodies are recognized on X-ray. It is equally important. In all cases related to ureter bladder, you have to go for X-ray plus USG abdomen. Because in lower urinary fistula, staghorn calculi can be caused. So we are going towards the system specific cause related to the site of fistula. Without that, it can be fistulography or sinusography if you want to know the exact extent. The dye injected is called as lipoidal. And above all, in the present tense, it is a MRI. Magnetic resonance imaging is one of the best investigations for any sinus or fistula, which will delineate the tract. Delineate is all different type of tributaries. Opening, either internally there is or not, everything can be seen on MRI. MRI fistulography is the best investigations for fistula in ano. Equally important is a biopsy from the edges. That is very true, because here you can diagnose whether it is tuberculosis or malignancy. That is how your examination in YY is proceeding. After all clinical parameters, examiner is going to ask you, how do you investigate? So these are the investigations practically for any type of fistula. But don't forget to mention the biopsy. And where biopsy is taken from? Biopsy is always taken from edge of a sinus. Then immediately last question is, okay, what is the management of this patient? Management is simple. Our management is to make the sinus heal or fistula to heal. As we know the causes of persistence of fistula of sinus, you must exactly tell the management. Sequestrectomy for osteomyelitis. Remove the dead bone, the sinus will heal. Anti-tubercular treatment for a tuberculous sinus. Whenever you are suspecting a foreign body like some metallic metal or some what you call a splinter, that is some foreign body like wood when the patient is working in the field, or it is suture material. Commonest cause of suture material is non-absorbable suture like proline. Mostly up to 3 to 5% of the proline do give rise to non-healing ulcer. Okay, so you remove the proline, the sinus or fistula will heal. Treatment with antibiotics, rest to the part, adequate excision, adequate drainage. So these are the basic principles of management of either a sinus or fistula. So whenever patient, our case of sinus and fistula, you must know these three things: examination, the palpation, then the inspection, palpation, and investigations. Probe examination is equally important, done with care. You have come to diagnosis, then it is a management. Management is to prevent the fistula or sinus from recurring. Understand? This is how your viva goes for the management of a sinus or fistula. Now comes the most common presentation for short cases in examination is the lymphatic system. Every time, one of you will always get a lymphatic system patient. Simple lymph node is also part of a lymphatic system. So what is it? Lymphatic system includes lymph nodes and lymphatics. Okay. So how do we proceed for examination? As usual, like all examination system, age. In history, age. What is the age of patient? Why? Tuberculous and syphilis are common in young age. Malignant lymphoma in young age and secondary lymphomas in old age. The duration, if it is acute, it is short. Chronic in tuberculosis, long duration. Affected group. This is the most important parameter for lymphatic. Remember, cervical group in tuberculosis, Hodgkin's. Inguinal lymph node in filariasis, lymphogranuloma or malignancy, or in our country, trauma to the leg. If there is pain, think of lymphadenitis. Painless lymph nodes, syphilis, melanoma, secondaries. If patient has got fever, particularly what type of fever? Evening rise of temperature is characteristic of tuberculosis. In filariasis, it is a periodic fever. Everybody knows whenever there is a full or a new moon, that is Purnima, fever coming on that day, you always think of a filariasis. You look for the primary focus. That means if you are examining lymph node, you must know the drainage area of that lymph node. So examine the drainage areas focus as a primary for the cause of lymphadenitis. Ask the patient about appetite. Loss of appetite and loss of weight is common in tuberculosis, malignancy. Pressure effects. If there are large lymph nodes, they are bound to give pressure and related effect somewhere. You must examine for that. Ask the patient regarding the past history of whether he has suffered from tuberculosis or he is suffering from some type of malignancy. Similarly, the family history gives some clue that tuberculosis and lymphosarcoma can run in families. So that history will give us idea. Yes, one of my relatives are suffering from tuberculosis and I may be suffering. That means this patient also may be suffering from tuberculosis. Physical examination. For all lymph node, it is very common. You have to consider the cause. So in general survey, what you will examine? What type of built-up patient is. Because in tubercular lymph node or a malignant lymph node, it is a malnutrition, cachexia, anemia and loss of weight. If you see patient with lymph node with this type of signs, think of tuberculosis or malignancy. Local examination. Local examination is probably more important because on inspection you have to remember the site because swelling at known site of lymph node, understand? If there is a lump in axilla or groin, you must think of a lymphatic enlargement, that is lymph node enlargement, unless proved otherwise. Don't give any other diagnosis in a lymphatic area. Don't say it is a lipoma, don't say it is sebaceous cyst in axilla. Always think of a lymph node. Examine number, position, side and surface. These are like a lump. Position is most important because where the lymph node is situated will give rise to from where it is coming. That is a lymphatic drainage area. How is the skin? Again, in acute inflammation, skin will be red. If there is a previous scar over the swelling on the skin, it will give rise to cold abscess or a previous surgery. Pressure effect, we have just studied. Pressure effect is edema and swelling of upper limb or lower limb can be due to axillary and inguinal lymph nodes. Nerve enlargement. Involvement of hypoglossal nerve is common in upper cervical lymph node due to Hodgkin's or secondary carcinoma. In esophagus lymph node, the presentation is dyspnea or dysphagia. So, depending on the site, you have to look for the what type of pressure it can give. Then comes palpation. In palpation, remember again just now I told you the normal lymph nodes are not enlarged. So, if there is enlargement of lymph node, there has to be pathology. The lymph node examination should be done with palpation by 3 fingers. That is palm of 3 fingers. You have to palpate lymph node like this, not like this. It should be like this. You feel everything of a lymph node. What are you going to see? Number, situation, local temperature, tenderness, how is the surface, and again the margin. You are examining it as a lump, but you must call it a lymph node. Most important, you have to palpate them for a matting. If the two lymph nodes are touching each other and difficult to separate, they are called as a matted lymph node. Matted or matting occurs because of a periadenitis, that means inflammation of the cover of the lymph node. That is why adjoining lymph node become matted, and this characteristic is most common in tuberculosis. Similarly, palpate for fixity to surrounding structure. Why it is important? That fixity gives us rise or our mind thinking towards malignancy. And fixity by palpation and movement. Where it will be fixed? It can be fixed to skin, it can be fixed to deep fascia, muscle, vessel or nerves. That fixity you must find out. That you can say that on palpation so many numbers is situated in right axilla and it is free. The swelling is matted. Matted swelling usually are adherent to skin. So your diagnosis ultimately goes to tuberculosis. Next, drainage area. You must be aware what is the drainage area of every particular lymphatic block. Cervical lymph node. When you examine, think of drainage from face, mouth, head and pharynx. The virtual lymph node, that is left supraclavicular lymph node, always think of upper limb, left side of chest, mainly breast carcinoma and upper abdomen. Whenever axillary lymph node drain upper limb, trunk extend from clavicle to umbilicus. That is for axillary lymph node. Inguinal lymph node drain maximum. The drainage of inguinal area starts from level of umbilicus down to the toes. Very large area for a inguinal lymph node. So you must examine inguinal lymph node in detail. Commonest cause for our country for multiple lymph node is continuous or recurrent trauma. Second cause of course goes to malignancy. Commonest among them is a malignant melanoma of a lower limb and penile carcinoma. Carcinoma of the testis very rare whenever they involve the scrotum. And it is also from the anal canal. Remember, anal canal is lowermost part and it also drains to inguinal lymph node. So you must know in the inguinal lymph node or the drainage. So this figure from book gives us clear idea. Deep cervical lymph nodes, supraclavicular lymph nodes, apical lymph node, serum. All the upper structures are drained into supraclavicular or axillary whenever they are above the umbilicus. Usually umbilicus is a terminal event or the differentiating factor, the upper part of the body and lower part of the body for the lymphatics. Always remember this. In lower part, commonest is inguinal lymph node and retroperitoneal lymph nodes. So this representation you must be aware which lymph node drains which part. In the neck, it is a level of clavicle and in the torso, it is the level of umbilicus. These two levels you must remember, whether it is above the clavicle, it is above the umbilicus or below the umbilicus. This differentiation you must know for the drainage area. And now the general examination. You have to also examine whether the lymph nodes are palpable in the other part of the body or not. For generalized lymphadenopathy, many of the groups are involved. So don't go by that particular side. You must examine opposite axilla, you must examine the neck, you must also examine the abdomen for axillary lymph nodes. Always examine spleen, liver, mesenteric lymph node, mainly in medical condition of a Hodgkin's disease. You have to examine the lungs in tuberculous or secondary metastasis. Look for the syphilitic stigmas in syphilis, associated syphilitic stigma. And in sarcoidosis, examine for the parotid or lacrimal. They are very rare. We don't have to bother. But once you palpate one group of lymph node, you must always palpate the contralateral group of lymph node. That is a basic principle for this general examination. So, after coming to the pathology of a lymph node, we have come to the diagnosis. Now, a very common pathology and very common question asked regarding the lymphatics. Lymph node is a solid structure. Lymphatics is a connection between two lymph nodes, lymphatic system. So, beside acute and chronic lymphangitis, lymphedema. Lymphedema is the most common major disease of a lymphatic pathology. And lymphedema is not going to leave you throughout your career because in coastal areas or South India, it is the filariasis which is the most common pathology. So, you must know what is lymphedema. By definition, it is accumulation of a lymph within the tissues. Very simple definition. Accumulation of lymph. Don't call it fluid. It is a lymph. In the tissue is a lymphedema. And it mainly affects subcutaneous tissues in the limb. Because the fascia prevents it from going to the muscle or a deeper plane. So this is very common question. Why they don't go deep? Because of fascia. Stagnation of lymph within lymphatics is also lymphedema. What are the types of lymphedema? As usual, primary, acquired. Primary cause, acquired cause. They are everywhere. This is very simple. Again, how do you proceed? Old pathology, old type, age, sex, distribution. In case of lymphedema, primary lymphedema occurs in young age. Secondary lymphedema occurs in our country usually in middle or old age. We don't know, but usually for a lymphedema, female sex is affected more. Particularly in an operated patient of a breast carcinoma, secondary lymphedema, that is cancer in cuirass over the arm, is most common after radiotherapy. This you must always remember. Distribution of lymphedema, it is very common as a filariasis, that is acquired lymphedema in tropical countries. Tropical countries means countries like India, Pakistan, Bangladesh. They are all tropical countries. That means between the 32 degrees, just above the equator. In our country, this is most common in Orissa and coastal Andhra Pradesh. Usually, few belts are there for filariasis in every region of the country, and you must be aware of that. So, always think of a diagnosis of filariasis when there is lymphangitis of extremity. What are the complaints? In congenital lymphedema, usually there are no complaints. Disease keeps on growing slowly over years. Patient is not much aware, but when it becomes very large, he is aware of that. As against, in secondary lymphedema, there is some complaint of inflammation. No complaint in primary lymphedema. Inflammation is a complaint in secondary lymphedema. Now local examination. Local examination, always look for lymphangitis. How it looks? Red streak progressing towards the renal lymph node. Remember, everything is go toward lymph node. All they are in lower extremity, it is inguinal region, upper extremity, axilla, above clavicle, it is neck. In case of extremities, there is a browny edema. Browny edema plus lymphangitis is classical of lymphedema. In all early cases, lymphedema pits on pressure. But when the patient actually comes to us, we always call it a non-pitting edema because there is more element of fibrosis and keratotic which is common in elephantiasis. How do you investigate? Blood investigations, aspiration. Whenever there is abscess, like cold abscess, you have to aspirate it. Mantoux test to diagnose tuberculosis, most common. Biopsy is the diagnostic investigation for a lymph node. Radiological investigation you can do, and what is called as a lymphangiography. Lymphangiography is sometimes done to find out the track of a lymph node, how the lymphatics are going. And this lymphangiography is diagnostic in case of a sentinel lymph node, done in all cases of malignancy, primary breast malignancy, and also in case of malignancy of penis. Okay, so that is lymphangiography done with the help of methylene blue or radioactive iodine. Lymphadenography, CT scan. CT scan done primarily in abdominal and mediastinal lymph node enlargement. There can be mediastinal staining and diagnostic laparotomy was done in the past, mainly in case of Hodgkin's disease, to know whether the diaphragm, they used to call it previously above diaphragm, below diaphragm. These are the staging of a Hodgkin's disease. Now that staging laparotomy is not done as a CT or MRI, is a non-invasive investigation which gives rise to what stage of a Hodgkin's disease we are presented with. So these are the investigations. Now comes the how do you cause? What are the causes of enlargement lymph node? As usual, inflammatory, neoplastic, autoimmune. That be idiopathy. Inflammatory, acute lymphadenitis, chronic lymphadenitis, granulomatosis lymphadenitis. Neoplastic, benign, malignant. But remember, in lymph node, benign are non-existent. It is usually a malignant lymph node. In leukemia, in many leukemia cases, it presents as a lymphatic enlargement. Autoimmune disorders like collagen disease or a Still's disease also a major cause of enlargement of lymph node. This enlargement of lymph node can be generalized or localized. Whenever you talk of general lymph nodes, the causes, common causes in our country is tuberculosis and Hodgkin's disease. Sometimes lymphatic leukemia. Rare causes now not seen: syphilis, infectious mononucleosis, sarcoidosis, brucellosis, toxoplasmosis, and lymphosarcoma. So these are the causes of generalized lymph node enlargement. Now this diagram is showing us how the lymphedema looks. On the right side, it is a complication of filariasis. What it is showing? It is showing all the complications. First is elephant leg, elephantiasis of the scrotum, and ram's horn penis. These are the complications of filariasis in our country. Unilateral lymphedema, whenever there is a pathology restricted to one limb, is more common in pressure on the lymphatics in the abdominal wall. Many times malignancy. Okay. How do you differentiate? This you must give few minutes to think. In acute lymphadenitis, cause is temporary, most likely pyogenic. If that antibiotic given and primary source is removed, the lymph node will regress. Okay, you understand? In short period, acute lymphadenitis, lymph node will regress with antibiotics. Common presentation in our country is tuberculous lymphadenitis. This is more common in children and young adults. By frequency involvement, cervical is most common. Then comes axillary, rarely inguinal, and deep-seated mediastinal and mesenteric lymph nodes. You must be taught in medicine, there are three stages of a tuberculous lymphadenitis. The first stage is, we call it as a lymphadenate stage. It is the early enlargement of a lymph node. And remember, there is no matting. Because once matting occurs, it goes into second stage. Why? Because matting occurs in periadenitis, which is diagnostic of a tuberculous lymph node. And third stage, come to surgery, it forms a sinus. Because now the caseation has occurred, it has burst and it has come to surface. It is a cold abscess with sinus, and this is the third stage which we are related as a surgeon. And sinus is refusing to heal. This is the third stage of a cold abscess or a tuberculous lymphadenitis. Syphilitic lymphadenitis not very common these days. What is the commonest for us? Is tuberculous and filarial lymphadenitis. In filarial lymphadenitis, it is an inguinal lymph node which is most commonly affected, and this condition is more common in males. Secondary filarial lymphadenitis, because they are more exposed towards the ground and moving out of the home. These lymph nodes are enlarged and tender. History of a periodic fever with pain, that is called as a dull pain during the full or a new moon, is a characteristic of a filariasis. In males, there will be enlargement of a spermatic cord with dilatation of lymphatic vessel called as a lymphangiectasis. Thickening of the skin in scrotum. Now remember, this is diagnostic of filariasis. If you see a filarial hydrocele, skin is very, very thick. You cannot pinch the skin. Microfilaria can be demonstrated in the blood which is drawn at 4 a.m. in the morning, which is a part of a government initiative. Eosinophilia is the role in filariasis, and sometimes biopsy of a lymph node can give or can show adult living filaria within them. Other rare causes are lymphoinguinal and infectious mononucleosis called as a glandular fever, and you are taught this in medicine, and non-Hodgkin's lymphomas. This is a differential diagnosis. For a surgeon, it is a tubercular lymph node or filarial lymph node, and rest diagnosis will be done by biopsy, because if there is a chronic lymph node, we must go for a biopsy to diagnose it and treat it. Okay. Now, our question is, the patient of a lymphedema has been kept in examination. How are you going to proceed if a case of a lymphedema? First, they will ask you, what is lymphedema? We have differentiated is the accumulation of lymph in a subcutaneous plane. If you want to give a better answer, the answer is accumulation of lymph node, extracellular, extravascular compartment and subcutaneous tissues, which results in enlargement of limb. That is a lymphedema. What is the fluid? It is a protein-rich interstitial fluid. What are the common sites? Lower limb is commonest, upper limb also can be involved. Next part, scrotum is involved. Second is penis is involved. These are the common involvement for a filariasis. We have seen the photograph. Lymphatic circulation. Remember, lymphatic circulation is as good as or parallel to lymphatic circulation. The primary function of lymphatic circulation is to remove the foreign bodies or remove the infection, kill them, take them into venous system and destroy it. This is the function of a lymph. The intrinsic lymphatic contractibility is responsible for the continuous drainage of a lymph. Whenever there is increase in transient pressure due to exercise and lymph, it will help the lymph to progress. And similarly, like venous system, there are valves in the lymphatics which prevent the reflux. In veins, there is a valve. In lymphatic also, there are valves. Remember this. So types, again, primary and secondary. Primary lymphedema occurs in younger age in different congenital system related to genetic, called as Turner, Klinefelter's and Down syndrome. Familial, usually it is the impairment of immune surveillance which predisposes to other malignancies. Primary lymphedema at birth, lymphedema congenita; at puberty, lymphedema precox; later, lymphedema tarda. So primary, we are not dealing much in primary lymphedema. We are dealing with the secondary lymphedema as a surgeon. Secondary lymphedema is an acquired condition. For all practical purposes, we will be dealing with two types. First is a viral elephantiasis and second is called as due to radiation or malignancy. The filariasis is caused by Wuchereria bancrofti. It is a common organism transmitted by mosquito. This is adult worm which has affinity towards lymphatic vessels. Initial lymphangitis with high-grade fever, chills, the streaks on the limb, tenderness and swelling of a spermatic cord. In case of males, if patient is having lymphangitis over extremity, you must examine the spermatic cord. If it is tender hot, you can easily diagnose filariasis. Lymph nodes are swollen and tender. Abdominal pain is due to retroperitoneal lymphangitis. Ultimately, what is going to happen? It is going to lead to fibrosis. Fibrosis gives rise to lymphatic obstruction. Lymph node obstruction gives rise to, or lymphatic obstruction gives rise to lymphatic dilatation. Understand? The whole process is going toward the formation of lymphedema. This is a photograph of a chronic lymphedema. In early cases, lymphedema is pitting. Progressively, it becomes non-pitting. And lymph is very important. It gives rise to good nourishment for the fibroblast. That is why fibrosis occurs very fast. These are how the lymphedema progresses. Subcutaneous tissue is grossly thickened. Now we are talking about viva. You must understand what you are supposed to tell and even what you are supposed to write in examination. Just go through this carefully. Presence of deep fascia prevents involvement of deep muscles of lower limb. This is very important. It never extends behind the fascia. What are the symptoms? Swollen limb, dull pain, feeling of tiredness, and even cramping pain. Loss of ankle counter. The ankle looks very different. Buffalo hump over the dorsum. It looks like this. Buffalo hump. Square toes. Square toes are diagnostic of a filariasis. And skin on the dorsum of toes cannot be pinched. You cannot pinch between two fingers. And that sign is called as a stemmer's sign. One may ask you in examination. Early cases pits, later on doesn't pit on pressure. So what are the clinical features of lymphedema? This chart is good. Go through it. Early signs, then is changing into late signs. Loss of ankle counter leads to fibrosis. That leads to chronic eczema. Buffalo hump on the dorsum of feet, dormal thickening leading to fungal infection. Stemmer signs, skin on dorsum of a second toe cannot be pinched because of a subcutaneous fibrosis. It leads to what? Hyperkeratosis, fungal infection. Early pitting on pressure, less on rest and elevation. That means in early stages, rest and elevation reduces the edema. Later on, it turns into fissuring and grossly thickening skin with rugosity called as a elephant leg. So these are all diagnosed as an elephant leg in lymphedema of a filariasis. So what are the clinical manifestation? Different parts. You also go through this. In lower limbs, acute stages, lymphangitis, lymphadenitis. Chronic called as lymphedema, chronic lymphadenitis. In scrotum, lymphangitis leading to lymphedema and chylocele, because whenever there is the white urine, you always think of a chyluria. Commonest cause for chyluria in our country is elephantiasis. Spermatic cord thickening, acute funiculitis leading into chronic thickened cord. Epididymitis, acute epididymitis leading to chronic epididymoarthritis. In abdomen, it is acute retroperitoneal lymphadenitis. In chronic cases, it leads to chyluria. In breast, it is lymphangitis to start. It can lead to lymphedema of the breast. So these are the clinical manifestation of a lymphatic filariasis, different depending on which organ is involved. So how do you compare the primary and secondary? In primary lymphedema, It is congenital hypoplasia or aplasia. Slowly progressive, younger age group, females more affected, usually unilateral, capillary hinge present, regional lymph node involvement is upset. And here surgery is excisional operations which are much better type result. Secondary, which we commonly deal is filariasis, rapidly progressive, middle age, males more commonly affected. It can start proximally and go into distal part. Lymph nodes are grossly enlarged in filariasis, and surgery is a excisional operation. On the right side, it is a post-mastectomy. See the lip. We feel sorry for that lady. It is cancer in cuirass. It is a lymphadermo progressive type, very painful condition after radiotherapy of breast. And in below, it is a unilateral lymphoedema due to proximal obliteration. This is a types of secondary lymphedema. And now, for your examination, it is nice to know that lymphedema in world commonest cause is filariasis. Most common for upper limb lymphedema in our country, again filariasis. In West, most common cause of upper limb lymphedema is post-mastectomy radiotherapy. Milroy's disease, asked in MCQ. It is a congenital lymphedema occurring below 1 year, is Milroy's disease. Meg syndrome. It is a familial form of lymphedema occurring between the age of 1 to 35. Stemmer's signs, always asked. It is inability to pinch the subcutaneous tissue. This Neblovitz procedure is a lymph venous anastomosis between the two lymphatics. There are number of surgeries. They are unsatisfactory lymphedema reduction surgeries like Charles, Sistrunk and thrombus. Common procedure which gives satisfactory result is Hammond's procedure. It is skin flap raising and subcutaneous tissue removal. The only drug approved for lymphedema filariasis in UK is oxyrutin. Finally, most common is chyluria, that is passage of milky white urine after fatty meal. 20% of a filariasis, 2% of the patient develop lymphedema. Very, very painful condition. So this is, you must know. Now these are the guidelines. Just go through this chart. You will know everything about management of a lymphedema. Lymphedema bandage is multi-layered. It is called as a MLD. Manual lymphatic drainage or massage may give rise to some relief. Prophylactic antifungal treatment to prevent athlete's foot. It is very common post lymphedema. So antifungal treatment should be given as a prevention. Maintain hygiene of the skin and foot. Weight reduction is equally important. That is advice on diet. Treatment of infection, it should be aggressive. Must instruct about exercise. Must follow compression garment. And surgery is whenever required. So the guideline for lymphedema is lymphatics. LYMPHATICS. This is given in chart. What type of surgery is done? Just go through it if possible. Remember. Types of surgery which we commonly do is Hammond's technique. That is excision and primary suturing of skin flaps. Other procedures are lymphatic bypass. The common surgery which we do is a omental transposition. What it is? It is a spontaneous lympho-anastomosis. That means the lymphatic from the foot obstructed are diverted through the mesenteric omentum. Excision with bypass are the surgeries like a Swiss roll and burial of dermal flap. But among them, only result satisfactory is a Hammond's procedure and omental interposition, where the mesenteric is brought down to the leg. So these are the various type of surgery lymphedema. This is for a short question. So we come to end of a management of a lymphatic and lymphedema, the examination of sinus and fistula. This is how we come to end of a surgical management of a lymphedema. So from next week, we have almost finished whole our syllabus. We have taken all type of surgery. We have finished all examination, all the question papers from 2008 to 2020. So next week for 2016 batch, which is exam going, we'll have a lecture only on Saturday between 10:30 to 11:30. And for the batches of 2016 and 17, syllabus is already completed and they will have no online lecture for 2017 and 18 admissions. 2016 admissions only on Friday between 10:30 to 11:30. Thank you very much and good day and Happy New Year again. Bye.